Now we'll see the current practice in the management of ocular tuberculosis. We have Dr. SANDHYA Somasundaran, Professor from Calicut Medical College. Over to you, madam.
Okay. Good morning. Actually, my job has been simplified by Dr. HD. Most of the slides will be overlapping, but it will just be a revision for you. So, as per Sun classification, the typical phenotypes as described earlier are anterior uveitis, intermediate uveitis, pan-uveitis, and posteriorly retinal vasculitis, choroidal tuberculomas, serpiginous-like choroiditis, multifocal or unifocal choroiditis. Now, as Dr. Rajani has previously described, we have a collaborative ocular tuberculosis study. And in that anterior uveitis, to be considered as tuberculosis, it should be typically granulomatous with mutton fat capies and nodules. It should be bilateral and recurrent, associated with iris granuloma and associated vitritis, extensive posterior synechiae, and seclusio pupillae. And also chronic non-granulomatous anterior uveitis also may be considered in this. So if you feel that the anterior uveitis has all these features, in an endemic country like India, you can consider starting ATT when one of the immunological tests is positive along with a positive radiological test. That is, either your MANTO or PPD is positive along with HRCT or chest X-ray. Regarding intermediate uveitis, actually the consensus was lower in the COT study group when compared to pan-uveitis. So they say in an endemic country like India, there was only moderate consensus to start ATT. Again, just like in anterior uveitis, when one immunological test is positive, along with one radiological test. Then again in pan-uveitis, similar. But in pan-uveitis, both in endemic and non-endemic areas, there was moderate consensus to start ATT when one immunological test is positive along with one radiological test. Then, as Dr. Rajani said, in active retinal vasculitis only we do consider it as tuberculosis. Active retinal vasculitis means you have features of vasculitis along with vessel involvement along with evidence of ocular inflammation. If there is no evidence of ocular inflammation, you consider it as inactive retinal vasculitis. So in active retinal vasculitis in endemic areas, absolute to moderate consensus was there to start ATT when one immunological test is positive along with one positive radiological test. So the conditions which we have described as of till now, that is anterior uveitis, intermediate uveitis, pan-uveitis, and for active retinal vasculitis, all these conditions in an endemic area like India, you can start ATT when one radiological test is positive along with one immunological test. In tuberculous choroiditis, the features are actually it can present as choroidal granuloma or tuberculoma. It can occur as serpiginous or serpiginous-like chorioretinopathy and unifocal or multifocal choroiditis. First is choroidal tubercles or tuberculoma. This is the most common and best clinically documented manifestation of ocular tuberculosis. So, since this is a highly suggestive phenotype of ocular tuberculosis, you can start ATT in an endemic country if only one immunological test is positive. That is, you need not have a radiological evidence to start ATT. Then again in serpiginous-like choroiditis, it is highly suggestive of tuberculosis. So again, in endemic countries, you can start ATT when only one immunological test is positive. But in focal or multifocal choroiditis, it can be tuberculosis, but you're not sure whether it is tuberculosis clearly. So since it has got weaker association, you need the support of one more radiological test. That is, immunological test plus one radiological test should be positive to start ATT. So among the conditions described till now, choroidal tuberculomas and serpiginous-like choroidopathy, we can start ATT based on positive immunological test alone. So this is the newer COTS calculator which is developed. You can scan the QR code and see. That will take you to the COTS calculator page. So actually it is for general ophthalmologists to guide to initiate starting ATT. Actually, it shows a page like this. You can enter the patient details in that, and you have a clinical phenotype in this. That is, in this clinical phenotype, there are many drop downs. That is, you can diagnose it as, you can mark it as anterior uveitis, retinal vasculitis. You have multiple options in that. And when you fill, finally, you will get a tab like this, calculate. And after that, you will get a score, which ranges from 1 to 5. And IQR, interquartile range, which ranges from 0 to 3. So if the score is actually, a score of 5 means very high probability to start ATT. And score of 4 means higher probability to start ATT is there. And IQR 0 means more than 90% of the experts that agree that you can start ATT. So that is an absolute consensus. Whereas IQR 1 is moderate consensus. So a result of 5 with an IQR of 0, 1, 2, and 3 is considered to have reached consensus to initiate ATT in that particular scenario. So in the COTS calculator, if you get a score of 5 with any IQR, you are safe to start ATT. Whereas if it is a score of 4, then it should be, the IQR should be either 0 or 1 to start ATT. Whereas a result of score 1 or 2 or 3 indicates a lower level of confidence for initiating ATT, but it doesn't say that ATT need not be initiated. There are a few clinical scenarios. A 34-year-old female came with complaints of defective vision for 2 weeks. She was having arthritis, which was diagnosed 16 years back, and had taken oral steroids for a short period of time at that time. That is almost 16 years back. She has bilateral renal artery and coronary artery stenosis. Anterior segment was normal. Visual acuity was decreased because of early posterior subcapsular opacity. Fundus showed a few orangish lesions suggestive of choroidal tuberculomas. So, Manto was positive. So, choroidal tuberculoma, according to the COTS guideline, you can start ATT when one immunological test is positive. But as again said in the previous talk, that is the previous session, this tuberculomas in the choroid can be due to sarcoidosis also. So in that situation, we have to, it is better always, but if the clinical is so suspicious of tuberculosis, then you can start. Here actually Manto was positive, IGRA was positive, but still we took an HRCT which showed multiple mediastinal lymph nodes, and the PET scan was also taken, which showed multiple active paratracheal, para-aortic, paracaval, multiple lymph nodes was there. But transbronchial ultrasound and FNAC was negative for CPNAT. And you can see the choroidal granuloma here and small choroidal granulomas in the other eye also. Patient was diagnosed to have disseminated tuberculosis and was started on ATT. The granuloma responded well to the treatment. Another 44-year-old female came with sudden onset of painless loss of vision associated with mild headache. She was diabetic and hypertensive. And on right eye, visual acuity was perception of light with grade 3 RAPD. There was no evidence of anterior uveitis. And fundus shows hazy view due to vitreous floaters. You can see an optic disc granuloma with few multiple choroidal lesions, multifocal choroidal lesions also. And the other eye also showed multiple choroidal lesions. So that is actually multifocal choroiditis with optic nerve head granuloma. Again, in our COTS study, actually it showed that multifocal choroiditis has got a weaker consensus. So it is always better to take an immunological test along with a radiological test. As we said earlier, optic nerve head granuloma can be suggestive of sarcoidosis also. Here also Manto was positive. HRCT showed central lobular nodules in adjacent lung parenchyma, which could be possibly due to tuberculosis. IGRA was positive. So in multifocal choroiditis, along with Manto, the radiological test is also positive. So we started on ATT and steroids. Patient responded well. Now another patient, again 60-year-old male patient with complaints of defective vision, left eye, history of tuberculosis in elder brother, anterior segment normal, posterior segment, yes, it is serpiginous-like choroidopathy in both eyes. And FFA was done. FAF again shows activity. Most of them are atrophic lesions, but some signs of activity was there. and diagnosed as serpiginous-like choroidopathy. Again, ESR was high, MAN2 positive. Serpiginous-like, it is highly suggestive of tuberculosis, so you need to have only one test. So again here in this, MAN2 was positive, all the others were negative. HIGRA negative, sputum AFP negative, chest X-ray, and CECT thorax also was negative. So since this was highly suggestive, we could start ATT with the basis of positivity of MAN2 alone. Now take-home messages. In anterior uveitis, intermediate uveitis, pan uveitis, active retinal vasculitis, and focal or multifocal choroiditis, it is ideal to start ATT when one positive immunological test is there along with one positive radiological test. Whereas in choroidal tuberculoma or serpiginous-like choroiditis, which is highly suggestive of tuberculosis, you can start ATT with one positive immunological test. And you can utilize the COTS calculator also for your guidance to start ATT. Thank you.
Thank you, Dr. Sandhya, for that excellent talk. Because the management of tuberculosis is always very confusing. Whether to start treatment or when to start treatment, you have given more clarity with your talk. Thank you.